Good morning, everyone. Today it is December 2023. You are in TransConnect, and we'll be talking about management of anemia and RBC transfusion. For this, I'll be inviting over my colleague, Dr. Soma Agarwal, who will be discussing this very important topic on RBC transfusion. Essentially, it will cover about the various algorithms and the approach to anemia, various types of anemia, how we should deal with it, and also special situations and special characteristics of various specialties where anemia may occur and how we combat that. So over to Dr. Soma Agarwal for the session.
The topics covered in this session would include a brief introduction about the topic, the classification of anemia, the pathophysiology which occurs for the anemia, approach to the various types of anemia, the trials which have been conducted for transfusion under different aspects of anemia, the guidelines which have been formulated, and how do we arrive at a decision for transfusion with patients of anemia. Starting with the introduction, the red cell transfusion is an extremely common medical intervention for medical and surgical indications. There has been shift in recent years from extensive to restrictive transfusion approach. So understanding anemia and the associated mechanisms behind it is a very important aspect for patient blood management. There have been evidence-based guidelines and recommendations which are essential for an appropriate and acceptable transfusion therapy. The World Health Organization defines anemia as a hemoglobin of less than 13 gram per deciliter in men and less than 12 gram per deciliter in non-pregnant women or less than 11 gram per deciliter in a pregnant woman. The oxygen carrying capacity decreases, but the tissue oxygenation is preserved well below 10 grams per deciliter. Coming to the causes of anemia, they have been classified into various aspects. One is the blood loss, whenever there is an acute or a chronic blood loss which can lead to anemia. Due to destruction or hemolysis, which is again further characterized into causes which are extrinsic to the RBC or which is intrinsic to the RBC. Among the intrinsic causes for the RBC destruction, it includes the hemoglobin disorders, the membrane defects, enzyme defects. And amongst the extrinsic causes to the RBC leading to hemolysis, it has been divided into immune and non-immune causes. The immune causes include alloantibody or an warm autoimmune hemolytic anemia or any other kind of hemolytic anemias like cold agglutinin disease, PCH, drug-induced. And the non-immune encompass the mechanical and the microangiopathic etiologies. The other aspect would be that whenever there is a less production of the red cells, it can also lead to anemia, and they are further classified as microcytic, normocytic and macrocytic, which we'll be discussing in the further slides. So let's understand what are the pathophysiological changes which occur in the body whenever there is anemia. So the aspects which are affected during anemia are the oxyhemoglobin dissociation curve, the hemodynamic alterations which occur in the body, the changes in the cardiac output, and the changes in the coronary and the cerebral blood flow. So we'll be discussing each one of them. This is the oxyhemoglobin dissociation curve. During anemia, there is a shift to the right and there is an increased level of 2,3 dpg levels also. So whenever the dissociation curve shifts to right, more oxygen is released to the tissues at a given partial pressure of oxygen. So this is well established in cases of anemia, excluding the hemoglobinopathies. The hemodynamic alterations which occur during anemia, whenever there is an acute blood loss, it leads to acute anemia or anemic hypoxia plus hypovolemia, which leads to a stagnant hypoxia. This activates the adrenergic system as well as the renin-angiotensin-aldosterone system. The renin-angiotensin-aldosterone system retains both water and sodium, thus helping in a conservation of the intravascular volume. Due to the activation of the adrenergic system, there is an increased sympathetic discharge, which leads to an increase in the myocardial contractility and the heart rate, which in turn leads to increase in stroke volume and cardiac output. Whenever there is an increase in stroke volume and cardiac output in cases of anemia, there is a diversion of the blood supply. So there is less cardiac output, or the less blood is supplied to the splanchnic, skeletal and cutaneous circulation, and majority of the circulation is diverted to the coronary and cerebral circulation. So in case the losses of blood volume is small, this leads to a orthostatic hypotension and it preserves the oxygen delivery to the vital organs. But in case the losses is very high, there occurs a organ hypoperfusion, which can also lead to a hypovolemic shock. In cases of normovolemic anemia, there is a reduced blood viscosity which increases both the preload and afterload, maintaining the circulation. This is a curve which shows the relationship between the hemoglobin and the cardiac output, which are inversely related. This solid curve is for a young healthy adult. The dashed line, this shows a young athlete, and the lower dashed line shows a person with a poor cardiovascular function. So there occurs compensatory changes in the cardiac output in normovolemic anemia due to decrease in the blood viscosity and increased sympathetic stimulation of the cardiac effectors. As we can see, as the hemoglobin level starts to decline, the cardiac output starts to begin, and the increase in the cardiac output is very good in cases of an healthy adult and young athlete in comparison to a person who's having a poor cardiovascular function. So the cardiac output begins to rise from as the hemoglobin falls from 12 to 7 grams of level in various studies. Coming to the microcirculation mechanisms which occur during anemia. So the microcirculation is composed of the arterioles, the capillaries and the venules, which have a diameter of less than 300 micrometers. The microvascular hematocrit is not the same as the systemic hematocrit. They are non-linear, and the hematocrit is lowest in the capillaries, up to 5% of the systemic hematocrit. Thus, this decline helps in counteracting the reduced flow velocities in the microcirculation. The microcirculatory effects, they adapt dynamically to the changes in the systemic hematocrit. The microvascular hematocrit is very actively regulated for the oxygen delivery. So depending upon the systemic hematocrit, the hematocrit and the microvascular keep changing to maintain the blood flow to the vital organs. But in cases of conditions like sepsis, diabetes or other conditions wherever there is a microvascular injury, this dynamic is disturbed. So the systemic transfusion, with systemic transfusion it is very difficult to influence the tissue oxygen delivery, because the hematocrit in the microvasculature is very, it's not maintained, or it is not linear to the systemic hematocrit. Also, while transfusing the stored red cells itself has their own mechanisms and storage lesions which affect the circulation. There is less of 2,3-DPG, which causes a left shift of the oxyhemoglobin dissociation curve, leading to less oxygen to the tissues. There is a rigid membrane of the red cells which causes a poor flow through the capillaries or the microvasculatures. However, whenever the studies have been done to compare the clinical outcomes based on the storage duration of the red cells, there have not been any significant benefit showing in the clinical outcomes depending upon the storage duration. There have been various bedside tools to assess the microvascular oxygenation. One is the NIRS, which is the near infrared spectroscopy. This is NIRS of the brain and the skeletal muscle. Handle vital microscopy of the sublingual microcirculation. significant microvascular improvement could not be seen in spite of systemic hemoglobin rise in traumatic brain injury, which requires a further large-scale evidence-based research. Coming to the interaction between the pathophysiological processes and anemia in the heart. Heart is a very vital organ which maintains the blood circulation throughout the body. So let's discuss about how anemia influences the pathophysiology in the heart. So heart has got a very high extraction ratio of approximately 60 to 70%, and whenever there is a decline in the or hemoglobin or there's an anemia, the extraction ratio further increases so that the oxygen is delivered to the tissues. The blood supply to the cardiac muscles occur during the diastole. So whenever there is an anemia, it leads to tachycardia, and tachycardia in turn causes a shortening of the diastolic period, which leads to a poor blood flow to the vasculature of the cardiac muscles. In cases of normovolemic anemia, up to 7 gram per deciliter of hemoglobin, the impact of cardiac circulation is less impacted provided the coronary circulation is normal or there has been no stenosis in those vasculature. Moderate anemia is poorly tolerated by perioperative and critically ill patients with underlying cardiovascular diseases. And patients with heart failure and valvular heart diseases, there has been an increase in mortality and morbidity because of the greater burden of adaptive increase in the cardiac output because of anemia. So this is coming to the brain. We can see the vascular supply of the brain over here. The hemoglobin and cerebral blood flow are inversely related in cases of normovolemic anemia. Increase in cardiac output causes an increase in the blood flow to the brain. Whenever the oxygen supply decreases, here also the extraction ratio begins to increase just like in the heart. So as per various studies, the global or regional cerebral blood flow depends on various aspects like the degree of hemodilution, the type of fluid used for volume expansion during anemia, the volume status or the preload status, the extent of the cerebrovascular diseases. Now these adaptive mechanisms like increasing in the extraction ratio and increase in cardiac output causing increase in the blood flow to the brain, they can be good or bad based on the pathology of the cerebrovascular diseases. For example, increased cerebral blood flow, it is bad in cases of increased intracranial pressure due to traumatic injury. Whereas in cases of subarachnoid hemorrhage, a mild normovolemic anemia can actually reduce the viscosity, which in turn improves the oxygen delivery during cerebral vasospasm. So there is a redistribution of the blood supply, increased supply to the cardiac muscles and to the brain, and this is because of the redistribution which occurs and the blood is shunted from the kidneys and intestines. So this affects majorly the critically ill patients. When there is a redistribution, it can lead to ischemia and failure of these organs. There is intestinal ischemia, bacterial translocation and multiple system organ failure. The microcirculation can get affected and impair patients' response to anemia and transfusions. Now coming to the approach to anemia. So if a patient walks in with a case of anemia, there are various parameters and history which needs to be taken into consideration. We need to evaluate about their family history, if there's any bleeding disorder, any congenital vascular abnormality, jaundice, etc. History about their occupations like drugs or chemicals which can affect the alcohol history, travel history, drug history, the dietary intakes, and we have to also evaluate the signs and symptoms of anemia. In cases of females, a menstrual history is also important. And on physical examination, we look for sternal tenderness, jaundice, the size of the liver, spleen. So So this diagram has been adapted from the Wintrobe's Clinical Hematology 14th edition for the evaluation of anemia. So we have to look whether is anemia associated with any other hematological abnormalities. If yes, there are other hematological abnormalities in terms of the WBCs or the platelets, we need to go for a bone marrow examination to assess for leukemia, clastic anemia, myelofibrosis, megaloblastic anemia and other reasons. If there is no associated abnormalities, we should check if there is an appropriate reticulocyte response to anemia or not. If there is no appropriate response, we have to look for the red blood cell indices. For the MCV, if the MCV is high, we have to look for the macrocytic anemia. If it is between 80 to 100, we have to look for the normocytic anemia. And if it is less than 80, we have to evaluate for the microcytic anemia. So if there is an appropriate reticulocyte response to anemia, we look if there is any evidence for hemolysis like increase in bilirubin level, increase in LDH, decline in haptoglobin levels and hemosiderin in urine. If these are there, we look for the causes of hemolysis and evaluate them. If not, then we look for the hemorrhagic causes of anemia. Approach to macrocytic anemia. Here is a picture of a peripheral smear of macrocytic anemia. It is important early clue to a reversible disease. It can be megaloblastic or non-megaloblastic. You can see hypersegmented neutrophil and oval and macrocytes, so macro-ovalocytes. So causes can be alcoholism, chemotherapy or nutritional deficiencies. So we have to check if the peripheral smear reveals any hypersegmented neutrophils or macrovalocytes. If yes, we need to look for the megaloblastic anemia. We need to have a bone marrow examination to confirm it. We need to test for the B12 and folate levels. If there is a vitamin B12 deficiency, we test for the same and we get the correction done. If there is a folate deficiency, again there should be a folate supplementation. If there is no deficiency, then there can be some inherited disorders of DNA synthesis or any drugs which are interfering with the DNA and it needs to be evaluated. If this peripheral smear does not show any hypersegmented neutrophil or macrovalocytes, it can be a case of non-megaloblastic anemia, and then we look for the reticulocytosis. If it is increased, then we evaluate for hemolytic and hemorrhagic anemia. If it is normal or decreased, we consider other causes like alcohol toxicity, hypothyroidism and liver diseases. The approach to microcytic anemia. In iron deficiency or impaired use of iron, the hemoglobin level declines. We need to check for the serum iron, ferritin, total iron binding capacity in such cases. The hemosiderin test, which are the bone marrow iron stores, also gives a clue about it. And specific tests for disorders of hemoglobin synthesis should be done. So this is a more detailed approach. If the reticulocytes are low or normal, we test for the serum iron, TIBC and ferritin level. Depending upon their combinations, for example, if the iron levels are low, the ferritin is also low and the total iron binding capacity is high, it shows an iron deficiency anemia. And if the serum iron is low and the TIBC is normal or low and ferritin is normal to high, we can consider anemia of chronic diseases. Similarly, if all three of them are normal, it can be due to hemoglobinopathies. In cases of sideroblastic anemias, the serum iron levels are high, the ferritin is also high, and the total iron binding capacity will remain normal here. So all these are to be considered in case the reticulocytes level are low or normal. If the reticulocyte count is increased, we need to again review the blood smear for abnormal morphology, and there should be laboratory tests done to rule out the red blood cell destruction, like we discussed the bilirubin, LDH and haptoglobin levels, and other hemoglobin studies to rule out the hemoglobinopathies. So in cases of normocytic anemia, these are usually presented as an initial stage of macro or microcytic anemia. they are associated manifestations of various systematic diseases, and this is the most common incidental finding. So if the reticulocytes are high, which shows there is an increase in the red cell production, and there is a history of jaundice, splenomegaly, or there are other blood smear abnormalities, and elevated bilirubin and LDH level, it points towards the hemolysis. If not, we need to evaluate the hemorrhagic causes. If there is a normal or decreased red blood cell production, then we need to evaluate about the erythropoietin levels, the serum iron, and depending upon all the results, we need to further go for the bone marrow aspiration, biopsy, and rule out other causes. So now hemolytic anemias can be divided into congenital or acquired causes. So we need to look for the degree of anemia, the jaundice levels or the bilirubin levels, if there is any aplastic crisis, the size of the spleen, liver, any cholelithiasis, leg ulcers, skeletal abnormalities, to rule out the congenital causes. So the acquired hemolytic anemia can be due to a transfusion of any incompatible blood, which is very rare. Fava bean ingestion or G6PD deficiency can lead to acquired hemolytic anemia. Autoimmune causes of hemolytic anemia, which can be warm or cold. Abdominal pain, muscle spasm, pallor or jaundice, or any other signs and symptoms of anemia should be evaluated. So the lab signs of hemolysis which should be assessed are for looking towards increased RBC destruction. We should evaluate the bilirubin levels, LDH, haptoglobulin, and the erythrocyte survival. And signs of accelerated erythropoiesis during hemolysis is a rise in the reticulocyte count. We should also look for the peripheral smear and the bone marrow. And the signs for intravascular hemolysis are the hemoglobinemia, hemoglobinuria, urine hemosiderin. Other tests which are supportive are the direct antiglobulin test or the DCT. In acute post-hemorrhagic anemia, the signs and symptoms would vary depending upon the magnitude of hemorrhage, and it can be symptomatic, it can be asymptomatic. If the loss is very less, the patient can be asymptomatic as well. And if there is a sudden onset of unexplained anemia, there is some covert bleeding happening which needs evaluation, and judgment will call for the red cell transfusion. Now, clinical outcomes of anemia and red cell transfusion. So whenever we have to take a decision to transfuse a patient, it should be taken after understanding the risks of blood transfusion, the ongoing risk of uncorrected anemia, the level of anemia at which the transfusion will benefit and will weigh over the risks of transfusion. So this is a graph. This shows a patient population with cardiovascular disease, and this is a patient population with no cardiovascular disease. In a population of patients who denied transfusion, the risk of death was higher in those with cardiovascular disease than without for each preoperative hemoglobin level. So underlying cardiovascular status is very important in deciding the risk of anemia. So there have been various clinical trials which have been conducted to assess these risks and benefit. So there was a meta-analysis conducted through January 2021 which included 48 published RCTs enrolling 21,433 patients under different transfusion thresholds. They were divided into restrictive and liberal. Restrictive being 7 to 9 gram per deciliter of hemoglobin level, and liberal being 9 to 10 gram per deciliter of hemoglobin level. It was shown that there was 41% less exposure to PRC component in the restrictive group. The primary outcome was 30-day mortality, and the results showed no clinical benefits or harm attributed to either restrictive or liberal transfusion. But these studies, the sole parameter involved in assessing it was hemoglobin only. So the other factors are also equally important while assessing, which are the clinical status and the other comorbidities of such patients. So there was a study done in critical care called TRIC trial or the transfusion requirements in critical care, 838 volume resuscitated ICU patients were involved in the trial, and they were divided into liberal and restrictive group. Liberal having less than 10 gram per deciliter of threshold and restrictive less than 7. The average hemoglobin levels in RBC units transfused was significantly lower in the restrictive group, but the 30-day mortality was slightly lower in restrictive group, although it was not found to be clinically significant. A similar study was done in patients undergoing cardiac surgery. It was known as Transfusion Indication Threshold Reduction Trial. Here 2007 patients were enrolled and again divided into liberal and restrictive with 9 grams and 7.5 gram per deciliter of hemoglobin levels. At 30 days, the difference in mortality or non-fatal MI, stroke, renal failure with dialysis, there was no significant difference between the two groups. There was another trial in cardiac surgery patient, which is TRIX-3 trial, or the transfusion requirement in cardiac surgery, wherein 5,243 patients were enrolled. There was a liberal group wherein less than 9.5 was a cutoff in operating room or ICU, and less than 8.5 gram was a cutoff in a non-ICU setting. And in the restricted group, the cutoff was less than 7.5. Here also there was no significant difference in infection, ischemic events or mortality. There has been a trial in orthopedic surgery, which is functional outcomes in cardiovascular patients undergoing surgical hip fracture repair. Here 2016 patients were enrolled and divided into liberal and restrictive of 10 gram per deciliter and 8 gram per deciliter of hemoglobin respectively. The primary outcome measured was inability to walk across the room without human assistance or death 60 days after randomization. There was no clinically significant difference found. In cases of acute myocardial infarction, there was a reality trial done, which is 668 patients with acute MI and hemoglobin of less than 10 grams were enrolled. And liberal was used as a 10 gram per deciliter cutoff of hemoglobin, and for restrictive it was 8. The primary outcome was 30-day outcome of death, stroke, recurrent MI or emergency revascularization. The outcome occurred in 11.1% in restrictive group and 14.2% in liberal group, with a relative risk of 0.7, which is non-significant again. A current study called MIN study is going on with 3,500 patients enrolled. In oncology settings, there have been trials on chemotherapy patients, stem cell transplantation, chronic anemia in patients with cancer and surgeries for cancer. The transfusion requirements in critically ill oncological patients RCT was done, and there was a high mortality with restrictive group than liberal group here. In cases of children, they are of special interest because there's a unique age-dependent adaptations to anemia. But there have been various studies, and studies did not find any difference between the liberal and restrictive transfusion groups with respect to survival, retinopathy, bronchopulmonary dysplasia. In cases of restrictive group, the apneic and neurological events were found to be increased, and the length of hospital stay was shorter in cases of restrictive category. There have been studies showing the effect of RBC storage duration over the clinical outcome. The storage lesions, like there's an excess of extracellular potassium during storage, decline in the 2,3 DPG levels, and excess of free hemoglobin and iron. So these have been studied on clinical outcomes in multiple trials, like the ARIPI trials in the neonates, the ABLE and transfuse trials in ICU patients, RESUS trial in cardiac surgery, total trial in malaria-induced severe anemia in children, and INFORM trial in the hospitalized adults. But all of these studies, they did not show any significant difference in the clinical outcomes. So based upon all these understanding of the pathophysiology and the trial results, there have been certain guidelines which have been formulated. So the AABB states that although they have given the guideline, they have got some precautionary measure, and they say that it can be changed or varied depending upon the clinical status of the individual. So the AABB states this practice guideline is not intended as an absolute standard. and it will not apply to all individual transfusion decisions. So when deciding to transfuse an individual patient, it is good practice to consider not only the hemoglobin level but the overall clinical context and alternative therapies to transfusion. The variables to take into consideration include rate of decline in hemoglobin level, the intravascular volume status, shortness of breath, exercise tolerance, lightheadedness, chest pain thought to be of cardiac in origin, hypotension or tachycardia which is unresponsive to fluid challenge, and the patient preferences. The ABB recommendations were restrictive transfusion of hemoglobin threshold of 7 gram per deciliter for hospitalized, adult, hemodynamically stable patients including critically ill, and a restrictive transfusion hemoglobin of 8 gram per deciliter for patients undergoing orthopedic, cardiac surgery and those with pre-existing cardiovascular disease. A restrictive transfusion threshold of 7 gram per deciliter is likely comparable with 8 gram per deciliter, but RCT evidence is not available for all patient categories. To keep in mind is these recommendations do not apply to patients with acute coronary syndrome, severe thrombocytopenia, like the patients treated for hematological or oncological reasons who are at risk of bleeding, and chronic transfusion dependent anemia due to insufficient evidences. There have been recommendations of 2018 Frankfurt Consensus Conference which states that less than 7 gram per deciliter in critically ill but clinically stable intensive care patients, less than 7.5 in patients undergoing cardiac surgeries, less than 8 in patients with hip fracture and cardiovascular disease or other risk factors, and 7 to 8 in hemodynamically stable patients with acute GI bleed. Now, decision making for transfusion. After having such a brief knowledge about the pathophysiology, the signs, the symptoms, the evaluation, the clinical trial results, how do we decide whether to make or whether to go for a transfusion or not? So, approach to evaluating a bleeding patient. So, there are various aspects which needs to be considered, which is degree of blood loss and the rate of bleeding. We have to check for the airway, breathing and circulation, the heart rate and blood pressure, in addition to a rapid scan of the scene and the patient to check for obvious blood loss. Emergency complete blood cell count, type and cross match coagulation profile. Crystalloid is administered to maintain the intravascular volume only if RBC transfusion is unavailable or bleeding is relatively mild. Emergency uncross-matched O-negative RBC transfusion to improve oxygen carrying capacity of the blood. Clinical assessment of bleeding and requirement of blood units. Whenever there is anemia, observed for the related signs and symptoms. Regular hemoglobin monitoring, and considering the history of angina, MI, CABG is essential because these patients are less tolerant to anemia. In cases of chronic anemia, there is enough time for compensation to develop, as in there is a decrease in viscosity, there are higher levels of 2-3 DPG levels, there is increase in cardiac output. So there is time to observe the patient and evaluate clinically important versus not important symptoms. If there is any cardiac symptom like angina and dyspnea, non-specific symptoms such as fatigue, weakness, dizziness or reduced exercise tolerance, and impaired performance of activities of daily living. And there's also time to implement alternative treatments to corrective anemia like iron, vitamin B12 and folate supplementation and erythropoietin. So whenever there is an acute blood loss, the rate of administration is based on the bleeding and the hemodynamic compromise. It ranges from 5 to 10 units over 10 to 15 minutes to 1 unit every 2 to 4 hours, which is 1 ml per kg per hour in patients with severe left ventricular dysfunction. In cases of chronic anemia, the dose should be just enough to relieve the symptoms. To remember is 1 RBC unit rises the hemoglobin level by approximately 1 gram and hematocrit by 3%. So to summarize, The RBC is transfused to improve the oxygen delivery to the tissues. The relationship between systemic and microcirculation hematocrit is nonlinear. The compensatory mechanisms are in place which redistribute the blood flow to the heart and brain, and the blood is diverted from the splanchnic and the renal circulations. There is a preponderance of evidence considering 7 to 8 gram per deciliter as a safe threshold for RBC transfusion. For cardiac patients, higher thresholds to be considered. And also, while deciding a patient to transfuse, apart from hemoglobin level, the comorbidities, the hemodynamic status, the symptoms should also be considered. Thank you.